reproduction. This is mixed reproduction.
Can you all hear me? Great. Okay. Peace, Africans. I'm so excited for you all to be here at this webinar this evening. My name is Cherise Brendan-Stelly, and I am the co-coordinator for the Black Alliance for Peace Research and Political Education team. The Black Alliance for Peace seeks to recapture and redevelop the historic anti-war, anti-imperialist, and pro-peace position of the radical Black movement. As your host for this evening, I want to start by thanking all of you for being here at our third webinar in the Black Power webinar series, which this one is titled Public Health, People-Centered Human Rights, and Black Liberation. Tonight's intergenerational conversation engages the interconnections of public health, or the work of prolonging the life, protecting and improving the health and preventing disease of peoples, their communities, and the population overall through a combination of education, policymaking, research, organized effort, and empowerment. Between people-centered human rights, defined by our national organizer, Ajamu Baraka, as the Black radical tradition's approach to non-oppressive rights grounded in the experiences of the people that reflect the highest commitment to universal human dignity and social justice that individuals and collectives define and secure for themselves through social struggle. And of course, Black liberation, or the complete emancipation, self-determination, and human flourishing of African peoples. This discussion is both timely and important in the context of the ongoing COVID-19 pandemic and vaccine apartheid, the attack on reproductive rights and its racialized and class effects, the resurgence of disease and illness as a direct result of neocolonialism, imperial occupation, and Western superexploitation, and increased spending on war and militarism. In fact, another $1 billion of weapons and aid was just approved for Ukraine today, to the detriment of the health and well-being of the majority, and many, many more sort of social ills that particularly affect colonized and racialized people. But as we'll hear tonight, our communities have always managed to care for ourselves and each other, organize for basic health access and resources, and fight against occupying forces that diminish our life chances. In terms of format, I'll introduce the speakers in just a second. Then our panelists will be in conversation about 4 broad questions. Then we'll open it up to the audience for participation and question and answers. So as a reminder, please drop any questions that you have in the Q&A section. And of course, drop your comments in the chat. So let me read some bios of our fantastic speakers. So Dev Springer, who will be moderating the first part of our conversation this evening, is a cultural worker and community organizer from Atlanta, Georgia, who works with the Walter Rodney Foundation and the Red Barrial Afrodescendiente. As a journalist, they've reported on incarcerated struggles, produced the documentary Parch in Prison, Pain and Protest, and helped found the former Docs Not Glocks campaign in 2015, which focused on policing and police violence as a public health crisis for Black people. They are the host of the Groundings podcast, assistant editor for 2 peer-reviewed journals, and are currently working on a documentary project which will highlight contemporary Black Cuban organizing. So welcome, Dev. Dr. Sandy Placido, my girl, is a historian, writer, and organizer from the Bronx, New York. She is an assistant professor of history at Queens College, CUNY. She researches and teaches about liberation struggles that have challenged colonialism, capitalism, and imperialism throughout the Caribbean and their diasporas. She is finalizing a book on Dr. Ana Livia Cordero, a Puerto Rican physician and revolutionary organizer who worked to empower and build solidarity between communities in the Caribbean, Central America, Africa, Asia, and the United States. Her work on Cordero has led her to delve further into the histories of anti-imperialist medicine and public health, especially in the Dominican Republic. Sandy is passionate about grassroots and artistic organizing with Dominican, Haitian, and Puerto Rican communities, and most recently helped create a group called Dominicans United NYC that has the goal of organizing for decolonization and autonomy in Haiti and the Dominican Republic. Oh yes, okay, let me slow down. Sorry, apologies to our interpreter. Okay, and finally, last but certainly not least, we have the amazing Dr. Patricia Rodney, who has lived and worked in Guyana, Barbados, England, Tanzania, Canada, and the United States. As a seasoned public health professional, her career spans the disciplines of health, adult education and literacy, social work, and women, gender, and development. In 1965, she received her state-registered nurse credential at the Royal Northern Hospital, London, England. In 1979, she received a Bachelor's of Science in Social Work at the University of Guyana. In 1988, she received her Master's of Public Health and Health Education and Health Promotion at Emory University, and a PhD in 2004 in Sociology and Adult Education at the University of Toronto. During her 15-year academic tenure at Morehouse School of Medicine in Atlanta, Georgia, she was promoted to MPH Program Director, Professor, Department of Community Health and Preventative Medicine, and Assistant Dean for Public Health Education. Dr. Rodney is the author of the amazing book, The Caribbean State, Healthcare and Women, an Analysis of Barbados and Grenada, 1979 to 1983, which was published with Africa World Press in 1998. And she also has published several peer-reviewed academic articles. And so if you do the math, next year is the 25th anniversary of this amazing book. So I recommend that everybody pick it up and read and study it. Dr. Rodney is currently an adjunct professor in the Department of Community Health and Preventative Medicine at Morehouse School of Medicine. Since 2011, Dr. Rodney has been the CEO of Partners in Health, Education and Development, an international development consultancy organization. She has worked in Ghana, Nigeria, Tanzania, Uganda, Botswana, Lesotho, and South Africa. Dr. Rodney is also the CEO of the Walter Rodney Foundation, established by the Rodney family in 2006 in Atlanta, Georgia. She is the mother of Shaka Rodney, entrepreneur, Kanini Rodney Phillips, a physician, and Asha T. Rodney, attorney at law. She is also the grandmother of Asia, Kai, Sky, and Apadua, excuse me. So welcome to all of our wonderful, wonderful panelists. And I'm going to turn it over to Dev now.
Peace, everybody. And Charisse, thank you for that wonderful introduction. As always, it's always great to get to be in a space with you and everyone, and to share space with the legendary Dr. Patricia Rodney and my new comrade, Dr. Sandy Placido. I'm really excited to be here. And I think that this topic is both important and timely when we talk about public health as it relates to Black liberation and people's struggle. And I'm excited because I already know that this conversation is going to be from a global perspective, and we're thinking through what public health means in a world of sanctions and imperialism, neocolonial strongholds usurping the resources of the underdeveloped global South. And my orientation to this field is as that of an organizer on the ground first and foremost. And so I am here to contribute, but also as much as I am to contribute, I'm here to learn from the two wonderful women who are here in conversation with me. And so with that, I would really like to go ahead and dive into the first question. And Mama Pat, I guess we can start with you and then work our way into the tangents of the conversation. And so we know that denying public health to racialized and colonized peoples has been a cornerstone of imperialism and neocolonialism. In your research and organizing, how have you seen this manifest in the Caribbean, Africa, the US, or throughout the entire African diaspora? You're on mute, Mama Pat.
Good evening, everyone. It's a pleasure to be here. I would start with looking at the structures in post-colonial societies, whether it's in Africa, Asia, the Caribbean, and Latin America, that those systems were hierarchical, patriarchal structures. And therefore, it also affected healthcare. We can't separate healthcare from what is happening in the rest of society. And so those systems were based on class, gender, and were race-based. Particularly in the Caribbean, and I think for Africa as well, we saw the degradation of colonialized peoples. There's a report that came out in the Caribbean in 1948 called the Moyne Commission, and that was a very important report. It's still very relevant, where it found that the Black population in most of the territories were affected by high infant mortality and morbidity rates. And many of the communicable diseases that we see re-emerging diseases were a result of poor living conditions and lack of facilities, things like inadequate and safe water supply and sanitation. Although the entire population suffered from these, women were particularly affected, poor working women and rural women. And so there was systemic gender discrimination throughout the Caribbean and throughout Africa and Latin America. And especially for women who were caregivers, childbearers, and child rearers were most affected, and particularly single women. I think that what happened after the Moyne Commission came out, then certain basic things were addressed. There wasn't any endeavor to revolutionize the healthcare system. It was almost a repair of the system, but not really a transformation of the system. And that's also true for education and other social services. They were modified, but they were not transformed. I think one of the more progressive things to come out of the 70s was the Alma Ata Declaration, which for the first time talked about health as a human right and health for all. Later on, we'll talk about how that was hijacked and why that process was hijacked, because it talked about inequities of healthcare around the region. Lots of governments bought into primary healthcare for all by the year 2000, but we know that never happened. And for several reasons, which we'll probably discuss later on. I'll stop there and perhaps Sandy can pick up from where I left off.
Peace, everyone. Thank you for the invitation, for everyone who has organized. And Dr. Rodney, thank you. It's such an honor. A lot of the things you said are things that I think about as well. I think when one studies the Caribbean, right, one sees that really since 1492, we've had a public health crisis, right? It's because one of the first things the Spanish did when they arrived, right, on the islands of the Caribbean was, well, completely break up family structures, right? And if so much of public health is premised on not just the health of the community, but also, I'm sorry, the health of the individual, but also the health of the community, we can already trace, right, that moment when the Spanish officials come and begin to divide the Taino populations based on gender, right? And so everything you said about how that initial colonial encounter was simultaneously a moment in which ideas about gender, race, and sexuality were created in order to further oppress and exploit. You know, it's all so interconnected, and this is why it's so important to look at all of these things when tracing the history of health and medicine and science and healing in the Caribbean. And of course, one of the things we see, as you mentioned with some of the commission's reports, is that even to this day, the folks who are at the very bottom when it comes to who has the worst indicators, right? It's again, it's the racialized people of particular marginalized genders and sexualities, so, and that are poor and that are rural and you know, all of that, right? Or but also urban populations. So in any case, in my case, I do study the Caribbean a lot, especially in the 19th and 20th century under US imperialism. But honestly, there's not necessarily a break. It's not like, oh, the Spanish Empire and then the US, or whether the French or the Dutch or whatever it may be. You know, there's really this continuity, right? When you think about who are the populations most violated, most experimented upon, most exploited, but also simultaneously most neglected and offered the less access to health and care, right? It's honestly women and children, poor women, poor Black women and children, you know. So you mentioned things such as maternal mortality rates, infant mortality rates. So some of the folks that I write about, those were precisely their concerns. Ana Livia Cordero is a 20th century figure, and she did work from the 1940s onwards, but that was essentially the types of things she was tracking in rural Puerto Rico in the 1950s, and then in Ghana, where she lived in the 1960s. Her community medicine projects in Accra, where I have it here kind of specifically on issues of maternal, neonatal, infant mortality, you know, statistics. This is 1962, 284 maternal deaths per 100,000 live births, you know. And what are the causes of death for those birthing people? Hemorrhage, toxemia, abortion, actually. And we can talk more about abortion later, but that's an ongoing struggle that has had a kind of a wave right now throughout Latin America and the Caribbean, the kind of fight for abortion access. In Dominican Republic, it's one of the few countries in the entire world where abortion, or at least in Latin America, where abortion is completely criminalized. Like, it's not allowed in any case, whether it's, you know, so we actually still, and I'll bring this up later, have very high rates of maternal deaths. So does Haiti, when compared to the rest of the Caribbean and Latin America. So yeah, and then some of the folks I write about in the Dominican Republic in the early 20th century, same issues, working with these impoverished, marginalized community members, right? But within the context of US imperialism, which is a whole nother set of violence that brings with it things, for example, like the sex work industry, which was another moment, especially in the late 19th, early 20th century, where you see a lot of violence directed to racialized and poor women, their criminalization, their punishment. Always the burden is on them and not on the military men, invaders, settlers, imperialists, capitalists who are coming in and bringing the disease, right? So, you know, in the Caribbean, it's been one epidemic after another, and there's definitely continuity. So thank you.
Absolutely. And, you know, I think when we think of the denial of public health as an actual tool of the imperialist state. I think a lot about Cuba and the US blockade. Specifically, we can look at the pandemic. You know, Cuba created 5 of the world's best vaccines for COVID-19 within the course of a few months before the rest of the world, but were unable at first to even distribute it because they lacked syringes, right? And you had to have a campaign around bringing syringes. And so the way that the denial of health transforms itself into being a bargaining chip and a tool by that imperialist state, by the US specifically, I think we can't overlook that. But I also think that when we frame this notion of public health, we have to have a very wide and sort of social scientific understanding of the context and material conditions as well. In 2014 and 2015 here in Atlanta, I helped start a project called Docs Not Glocks. And we brought together doctors, public health professionals, nurses, community organizers, mental health workers. And it was essentially a large research project looking at the intersection of policing and police violence as it intersects with Black people's health. And we meant health in a sort of fundamental way, right? Like your physical health, your mental health, the well-being of your home. All of these things are impacted for Black people in the US by the police. And so from that, what we concluded obviously was abolish the police, you know, obviously. But on top of that, of course, was this notion that the police themselves are a denial of public health for Black people. Because specifically, we looked at mental health crises. You don't have a trained mental health professional who comes to help you as a first responder. You have armed police officers of the state. The majority, I believe it was 80% of incarcerated Black people in the US, and specifically in the state of Georgia, which is where we did our research, are dealing with a form of mental illness, usually sort of a multiple layered diagnosis, right? And so we looked at all of these things to look at not just the numbers around infant mortality and maternal mortality or, you know, vaccination campaigns, but we wanted to sort of broaden the scope of what we know as public health and to show, in fact, that the arms of the state, as violent as they are one of the largest, impediments and barriers to health. And we also have to think about the hospital itself as a highly policed place and zone. And there's a reason why Black people en masse, particularly homeless Black people and poor working class Black people, usually don't access services that do exist, right? Because it's a site of violence in and of itself. And so we can move on to the next question, but I wanted to throw that 2 cents in there. And both of you actually touched on pretty heavily the gendered impacts of the lack of access to public health, particularly due to imperialism and colonialism. And so I'm wondering, what would you say are the gendered effects of lack of access to public health and medical care, and what policies, structures, and practices sustain this foreclosure?
Before we go on, I want to talk about health and public health, because most times we see health in a medical model, and we focus on ill health rather than people's health. And what is now called the social determinants of health are all the things you talked about: housing, lack of education, food deserts, all the other social things that we don't particularly pay attention. And particularly in the US, where the healthcare system is so fragmented that people across sectors may not talk to each other, but also because health has become a commodity rather than a right. So if you don't have the resources And most working class people, a large amount of people in the United States do not have access to health, because healthcare, in fact, is linked to your job. And if you lose your job, then you lose healthcare. So we want to broaden how we look at health and healthcare and public health, because public health is about prevention. It's about community health. In a medical model, you look at one person. In public health, you look at what happens within the community, what happens within the family. So it's important that people understand what you have, and what you have in the US is a very fragmented approach to health and to public health. As we know, a lot of resources, because it's commodified, a lot of the resources are based on the pharmaceuticals and other kinds of monetary gains. It's not based on people-centered healthcare. So how do we address that, whether it's in the Caribbean, whether it's in the US? How do we ensure that public health plays a more prominent role? We see public health only when there's a crisis situation, that we respond like to COVID, and then we forget about it, and we respond again when there's another outbreak of something else. We're not really building a system that responds to people's needs.
Yeah. That's so helpful. You know, through my research is how I've come to learn more about public health, because I'm a historian. You know, I don't have an MPH like Dr. Rodney, and then but then because I write about people who either had MPHs or were MDs or were doing this type of work, I've immersed myself and learned more. And exactly, thank you, Dr. Rodney, for that definition, because in my research, that's what always the conclusion of some of the Caribbean, I call, you know, Caribeña physicians that I write about. Their conclusions tend to be, in order to address this problem, we need community, it's preventative, it's a preventative project. So it's not about being, you know, reacting to the presence of ill health. It's about making sure that we are maximizing health by doing preventative work, and also education, right? Those always tend to be the conclusions. Another very important conclusion always is, hey, we already have these resources within our community. We have these kind of organic leaders in our community, usually, again, marginalized genders and sexualities, women who are already kind of these respected people in our community who are doing that care work, who are doing that healing work. I mean, when you really think about care work, that's something I think a lot about too, that is so important. When you really think about people who are taking care of our elders, the children, who are taking care of, like, yeah, I mean, it's, all of it is gendered, all of it is racialized, all of it has everything to do with class, like, absolutely. So I've been so grateful that some of the figures I write about have pushed me into the arena of health, because it has really taught me some of these really important strains. The family, I saw some people in the chat were like, exactly, the family. And that was some of the work that Ana Livia Cordero was doing in Ghana when she was in Accra in the 60s. She was working in Jamestown, which is a section of Accra. It's like a fishing village. And she was the head of a maternal health clinic. And one of the things she did, because at that time Nkrumah had set up something called the National Institute of Health and Medical Research, and she was a researcher and a professor, and in working within NIH MR. And one of the things she found in doing research in Jamestown is like, oh, we can actually reduce these mortality rates by just going into people's homes, going into the churches. And some of her former students that I was able to interview, they actually said, and this is part of the colonial story as well, that before her, they had never had a professor who had taken that community approach. That before Nkrumah and the independence of Ghana, the trend was to go to medical school in the metropole, you know, whether it was England or Scotland. But after, I think Nkrumah helped, you know, get the medical school founded by 62, 63, and Cordero was one of the first medical school professors, and she even kind of distinguished herself because she was one of the few people even then who was like, no, we need to go out and do community health surveys in rural communities. And so I have all of this great research that I've been able to find about all of the kind of, and you really read it, it's really a method, right? Public health is a science, it's a method, it's a sort of way of, yeah, it's very much, I mean, it makes sense within the fields of, you know, social sciences, really kind of taking that more bird's eye view from a lot of the tools we have from whether it be Marxism or revolutionary theory is also, it overlaps really well because it's always about sort of taking that bird's eye view. Yeah.
I'll just pick up where, because I was very influenced by what I saw in Cuba. Just what you described, that, you know, all doctors are trained in public health. So they have a different orientation to medicine. They see public health as very vital. And I think that's why, despite the embargo, the system has been able to survive, because people understand and know what is important for their health and well-being. Is not just about medical care. It's about free education. It's about literacy. It's about food. It's about family. It's about caregivers. And we see that connection between the Cuban doctors and the Cuban society, which is very unusual because doctors are trained in this hierarchical method that they have all the knowledge and they tell you what to do. There's a dialogue that goes on between the Cuban people and the medical profession, which is unusual. I haven't seen that anywhere else. When I did my research in Grenada, and I was talking to the women in the clinics, that was after the invasion, the US invasion. I was talking to women in the clinics and asking them what it is that they felt was now lacking within the healthcare system, because there were lots of Cuban doctors in Grenada helping them to build a different kind of healthcare system, and not a medical model, but a public health system. And the women said what they admired a lot about the Cuban doctors, although they had problems with understanding them, they were speaking Spanish, they had to go through a translator, they found them very humane. The doctors respected them, the doctors treated them as human beings, while some of the other doctors who were trained on the Western model were not as nice to them. They looked down on them. So you see the difference in terms of how training is done in Cuba, that health and healthcare is a human right. And it's probably one of the only countries within the region that has followed through on the Alma Ata Declaration. And despite the embargo, I mean, we should be really screaming about them, you know, removing this embargo. It's inhuman. It's an injustice, not just to the Cuban people, but to the whole of the region.
Absolutely, very quickly, because you're talking about the Western model, because a big part of the story I have learned, right, is actually the professionalization of medicine and of the privatization of it, and also, right, so the like literal development of like medical schools, you know, they haven't always existed, but in the moment in which they, you know, they are premised on exclusion, right? So it's like, I think someone mentioned in the chat, I just saw we our communities have always been taking care of each other and healing each other. But then in that process of professionalization, all of a sudden, all of that healing work becomes, masculinized. It's like a patriarchal, like, so it's like for the men, it's for the elite, and it's for the whites, right? So it's like all of these former community health workers, if you will, right, are so like kind of outside of that model, and they're not respected or seen as kind of having any sort of knowledge, right? So anyway, I know that both of the folks that I write about, Evangelina Rodriguez, who was the first woman to become a doctor in the Dominican Republic in 1911, and who was a Black woman, she had to fight her way into medical school at that time, and it was a really hard fight, and they ostracized her. She was eventually killed by the Trujillo regime, but she was radicalized because she was treating patients in the rural parts of Dominican Republic during the US occupation. And literally occupation is, again, premised on displacement and literally killing people in order to take their land and resources. So she became radicalized because her patients were literally getting killed. So in any case, I'm just kind of, it's just so interesting, that kind of process of how throughout, especially the 19th and 20th century, you see the actual education industry really becoming more and more exclusive, right? So.
And, I'm so glad both of y'all hit on anything I had to add. Both of y'all, hit on it perfectly. I just wanted to say, when we think of the gendered effects of lack of access to healthcare in the context of the Cuban blockade, since Mama Pat, you brought up the blockade. One of the things that over the past several years, 4 or 5 years, that I've been working with is with the TLGBTQ communities in Havana and Matanzas, Cuba specifically. And due to the blockade, they cannot, because Cuba, with health being a public good and human right, they have free, on-demand, unrestricted healthcare, as well as gender affirmative surgeries and other healthcare needs that are specific to the TLGBTQ community. And they have, in terms of rights and access to care, way more than the TLGB community, especially the Black TLGB community in the US has. But particularly, they have issues around getting items because of the blockade, like condoms, dental dams, lube, hormones like testosterone and estrogen, binders. So all of these things. And so what they've done is they've created literal networks and community funds where whatever small resources they get, whether it's through donations from delegations or from international organizations or found amongst the island, they share and spread amongst each other. And the state public health department, alongside CENISEX, which is the National Center of Sex and Health Education in Cuba, actually encourages and supports them in their horizontal grassroots efforts as like the LGBT community. And so they have a two-way system in which, because of the blockade, there's many things that they have to fend for themselves in terms of healthcare. And at the same time, they have a state that understands where its limits are due to that blockade and step in to then help the people empower their own communities right where they are. And so I just wanted to throw that example out when we talk about gendered as well as sexuality in this case, the impacts and effects that lack of access can have. And that's a direct result of the US blockade, again, in the blockade. And so moving on to our next question, because I can talk about Cuba all night. I want to ask both of you, maybe we'll start with Sandy, because Mama Pat, I got you the first 2 times. What are some historical and contemporary Black movements, organizations, and individuals that have resisted the denial of access to public health care, facilities, and resources?
Mm-hmm. Yeah, so, what I'll say about, I had mentioned Evangelina Rodriguez, the first woman doctor in Dominican Republic in that period, the early 20th century. The US occupied DR from 1916 to 1924. I'm sure many of you know they were simultaneously occupying Haiti as well from 1915 to 1934. And so part of, again, right, I think some of you may know that why were they occupying? A big part of it, it's kind of similar to sort of the history of Puerto Rico more recently, right? There's this sense of like these countries who don't know how to manage themselves because, again, they're these racialized, like Black people. They're incompetent. Not only are they incompetent and Black and too revolutionary, but they're also, they have extreme amounts of debt, right? So a big part of why the US is in the Caribbean is this sense of like restoring order, the sort of dollar diplomacy, we're gonna go in and help you guys. And so I would actually I would give that as an example, because a lot of the folks who were fighting on both sides of the island were literally Black. I mean, most people in DR and Haiti are like of Afro descent. You know, we have a mixture and a spectrum, but I think, you know, overall, right, if you look at who some of the actual guerrilla fighters were during those occupations, they were actual like Afro descent people who are visually kind of identifiable, like someone like Liborio, who is more and more people are talking about him in Dominican studies, but he was a folk healer, and a lot of people know him as that, but he was also a guerrillero, like he was in the mountains and leading people across the mountains fighting the US Marines. I'm trying to learn more about this figure, but I believe the name is Charlemagne Perrault, who was doing something similar on the Haitian side. So I would identify them. I would identify, again, Evangelina. She herself was actually a Black Dominican woman, and that was one of the reasons she was so ostracized. Not only because she was publicly speaking out against Trujillo and US imperialism, but also because she was a woman and a Black woman in medicine. You know, that created a lot of tension because of the patriarchy at the time. That's why it was hard for her to sometimes get certain types of jobs. And she did it, you know, she wanted to work with rural populations, but part of it is like, you know, she wasn't also going to be included necessarily in the most elite positions in medicine at that time. So I identify her. Ana Livia Cordero, who I read about, even though she herself was a light-skinned Caribbean woman, she was always prioritizing the importance of Puerto Rico within the larger history of the African diaspora, and she always was intentional through her organizing in the 60s and 70s to work with Black Puerto Rican populations and in Ghana. And then, yeah, one example that Joanna Fernandez, who I admire a lot, writes about, I always think about the Young Lords. You know, when I read that book, and I've reread it multiple times now, one of the things that most stands out to me about the Young Lords is like, wow, like a lot of what they were doing was actually public health. Like, so it was the tuberculosis campaigns, right? And you realize it's not that long ago that there were still very high rates of tuberculosis in a place like New York City. So we're talking late 60s, early 70s. So tuberculosis, they were working on, they occupied Lincoln Hospital, and they did the garbage offensive. All of these are public health concerns. And of course, they were a population of, yeah, a Latinx group, but obviously many, and if not most of their members were Afro descendant, as well as US based Black folks. So those are some examples, yes.
I think throughout the Caribbean and Africa, the unsung heroes were lay midwives who may not have been professionally trained, but it was a tradition that was carried on in families. So lots of the births took place at home, and these women sometimes were demonized by professional trained midwives. In Senegal, for example, during the colonial period, all traditional medicine had to go underground. They were seen as illegal and they could be imprisoned. In Senegal, they've made traditional healers are now part of the established medical system. They work along with the professional trained doctors. And this was because they found that the population naturally went to the traditional healer first, and then went to a professionally trained doctors. And they realized that in order for them to really treat a patient, they had to have some way of integrating traditional medicine into the regular system. I've seen this happen in Canada as well, among Native Canadians who have gone back to the traditional healing They're trained doctors in the Western medicine, but they've also gone back to using more traditional methods, because that's the only way that you can deal with a population who are very suspect of modern medicine. And they have reasons to be. We know of all the Tuskegee experiment, but this also happened in South Africa and other places where poor Black people were used to as non-humans to experiment on to progress medicine. Some of the I talked about lay midwives also because hospitals were always segregated. You had Black doctors in the US and other places not being given the recognition that they needed. And that was one reason why a lot of like the historically Black colleges and universities, they also had to establish their own hospitals. But one of the groups that particularly impressed me was the Black Panthers. We talk about them. When I started reading about the Black Panthers, you only saw them as men with berets who wanted to fight, right? Berets who wanted to fight. But you never saw the humanistic aspect of them. And since then, there's been a lot of research around them as the first public health mission within the United States for Black people, because they just didn't only focus on feeding children. They saw public health as a human right, and that they demanded that people receive free health care, which has never happened in the US.
Definitely, and I'm so glad the two of you brought up the examples of the Young Lords and the Black Panthers, both being excellent examples. The Young Lords, when they discovered that the rates of tuberculosis were extremely higher in Black and Puerto Rican neighborhoods, particularly because hospital staff refused to go into those neighborhoods to do testing the way that they went into white, wealthy neighborhoods to do testing. The Young Lords proceeded to hijack tuberculosis testing trucks and bring them to their neighborhoods and administer testing and treatment. And so I love that. And then of course, the Black Panthers were very big about community health and sickle cell research, treatment, help to the community, a lot of elderly care. Former Black Panther Sophia Bukhari, may rest in peace to her, but she talked a lot about how elder care was actually a primary goal of the Brooklyn chapter of the Black Panthers. They had assessed the needs first of the community and realized that there were elderly people who had trouble getting to the doctor's office, getting to get their medicines, getting groceries, just a host of different issues, or needing their blood pressure checked every day. And they created the infrastructure on a neighborhood level to go through and to do that work, right? And so I think those are two incredible examples. And I'm wondering, Patricia, if just a little side question, if in your experience, maybe in Tanzania or Grenada, if there's any examples that are similar to what you've seen in the US with formations like the Black Panthers and their approach to health.
Not really. Working in Tanzania, I was working within a very structured system. So there wasn't a lot of non-governmental organizations working on those issues. Health was seen as the premise of the government. So all services were carried out through the government services, whether it was maternal and child health clinics, nutrition clinics, vaccination clinics, school health, which is one of the areas I worked in, school health. And we used to go out to schools to treat children, but it was a very traditional way of treating the children. You only treated the children who presented with a problem. And so you treated that problem and send them off back to, we never really went out to the homes to investigate why this child was having this recurring problem. So I think there was gaps in the system. And I need to say that a lot of what happened in these post-colonial societies, after independence, they tried to modify the systems. They didn't try to change them. The only country that changed the system was Cuba. But the structural adjustment policies in the 80s really impacted even the basic public health infrastructure, because the focus was on paying back these debts to the World Bank, and therefore all the social services had to be cut. So people were working under very difficult circumstances. So I want to make that clear. It is just that it isn't that things weren't happening, but it could have been better if perhaps those governments had followed Alma Ata Declaration and instituted health for all. And we know those things were hijacked by the US government, by people like, he's slipping my, Bill Gates, because they had a particular focus on how healthcare and public health should be organized. And so when we're looking at public health globally, we have to take into account that it's become commodified. And so how do we, as activists, public health, because I think more public health people need to become activists, how do we as public health activists challenge the current system that we face? Because we've seen how many people died during this COVID epidemic, and most of them were poor people, poor Black and colored people who did not have access to primary health care. And therefore, they were not had access to the vaccine. And when they had access to the vaccine, it was costly. It wasn't, free for them. And that extended also to other developing countries who could not afford to buy the vaccinations while they were being hoarded in Western countries.
Thank you for that global perspective, for sure. And the final question is one of my favorite questions to ask, because it's the tangible walk away question. What are some concrete examples of radical Black organizations forging public health initiatives and practices in their communities?
I guess I can begin. I definitely have a few organizations that I can mention, but very quickly related to the former point that Dr. Rodney was speaking about the importance of resources, because exactly, we can have visions and the will, but with these sometimes with some of this healthcare, it's you need tangible objects, resources. So anyway, I just wanted to quickly share something Ana Livia wrote. It was a journal article she wrote in 1964 that she published in 1964. It was actually based on research she had done in Puerto Rico in the 50s on how to maximize the efficiency of care, because one of the issues is you have a lot of people but not enough doctors. So another part of public health is about how to kind of it's about efficiency, it's about management, it's about the kind of algorithm of like how things, but anyway, she has this one line here. that reminded me of what Dr. Rodney said. This study has shown some of the problems that arise when the goals and standards of a developed country are transferred to a developing country. So she was always critiquing, again, in the case of Puerto Rico being a colony of the United States, right? The imposed standards mixed with the lack of resources and then linked with the like broader trends of privatization that are, you know, the structural adjustment program, it's just a recipe for disaster. So I wanted to bring that up. You know, some of the organizations that I've really come to admire right now doing work, for example, in Dominican Republic, they're called Movimiento Socialista de Trabajadores. I have a link somewhere. They stand for the socialist movement of workers. And I like them because they're doing this like really important organizing work in the Dominican Republic right now, where there is a fascist right-wing pro-US imperialist government that is extremely xenophobic towards Haitians and racist towards all Black people and super violent to all poor people and women, pregnant women, the abortion. So, you know, I feel like they've really done a good job, if you check out their website, with some of their publications, and always kind of taking all of these individual issues and putting them in this larger frame that is the story of, you know, the histories of imperialism, capitalism, et cetera, and how they manifest in like a million different ways, right, in all of our, so that's one org. But in Puerto Rico, I think I sent a link to the folks. There's one group that I followed a little bit in the wake of Hurricane Maria, Centro MAM, M-A-M. So it stands for Mujeres Ayudando Madres, so women helping mothers. And I remember donating a lot to them early on after the hurricane, because I loved that in the wake of the hurricane, when there were so many issues, right, that we could be kind of talking about that were necessary to address in Puerto Rico, they were really paying attention to, again, the question of maternal health, kind of, you know, non-privatized like birthing. So that's two. I had mentioned that we have this group that we started, Dominicans United, where part of it is not that we only want to work, you know, we really want to address the island as a whole, Haiti and DR, but we realize there's a need to raise the consciousness within the Dominican community, because we have lots of contradictions that are the result of our, you know, very complicated history. So those are some, but yeah, there's like way more. So I'm just gonna stop there. Yeah.
Okay. One of my favorite organizations, and it's one of the reasons I did public health at Emory University, was the Black Women's National Health, the National Black Women's Health Project. And I first met them in a long time ago in 1985 in Nairobi at a women's conference. And then I organized a Caribbean women's conference in Barbados. And when I got my fellowship, I decided to come to Atlanta because I wanted to continue the work with the National Black Women's Health Project. It's now called the Black Women's Health Imperative, based in DC, and they mostly focus on policy issues. And then the Center for Black Women's Wellness, which is in Mechanicsville, Atlanta, Georgia. And I worked closely with this organization when I was the director of the public health program at Morehouse School of Medicine. And then my other favorite, my very favorite, is Sister Love. It's the oldest women-centered HIV and reproductive justice nonprofit in the southeast of the United States and based in Atlanta, Georgia. Those are my US ones. And then I go to Canada, and I worked with this organization in Canada. It's called Women's Health in Women's Hands. And it you know, you could look it up on the website. And it is a community-based health center for racialized women living in Toronto and surrounding municipalities. And in Guyana, of course, is Red Thread. And yeah, those are my organizations. There are many more, but those are my favorite ones that I've actually worked with.
I wanted to give a quick mention to, in environmental justice movements, environmental health, like in the Dominican Republic, one of the big things I've been involved in is the anti-mining struggle. You can imagine, right, all of the toxins, right, that are produced through the mining in the case of DR of gold and silver, but we have this all throughout the world, right? That resource extraction, which is so bad for the actual, the environment, is also so bad for humans. So, there's like so many examples of that all over the world. The water defenders in Puerto Rico, they were dealing a lot with like toxic ash deposits and, everything related to climate change as well. So wanted to put that out there.
Definitely. Thank you both for that. And thank you, Sandy, for connecting it to the larger climate, especially here in Atlanta, where I am, as it's hitting close to 100 in June, and we're having heat strokes and whatnot at record rates, as I was reading earlier today. Hopefully that's more and more in the forefront of people's minds. And I wanted to give a few examples as well. One of them being Jaleesa Jackson with ARC Southeast. This is actually an abortion clinic and a maternal health resource center, and they view access to abortion or lack thereof as a public health concern, and particularly looking at how the recent abortion ban, for example, that the Supreme Court is poised to drop at any moment, how that in itself is a public health crisis, particularly for Black and Latin women in the US. And so what they've been doing is creating networks and supporting networks which have created mutual aid funds and community resources, including education for safe self-abortions and a whole range of different education that goes in with that. And Jaleesa Jackson is an incredible thinker who has put lots of boots on the ground and time spent in communities doing this work. And then to take it back to Cuba, the Red Barrial Afrodescendiente, for those who don't speak Spanish, that roughly translates to the Afro-descendant neighborhood network. Sandy, correct me if I'm wrong. And they have a model and approach where they're embedded in the community so deeply and in such a way that their org isn't coming from a top-down position and telling the community what they need for their health. The community comes to them and says, this is what I need you to organize as organizers. And so when the pandemic began, they've been working formally under the organization, the RBA, since about 2012, 2010. And when the pandemic hit, they already actually had the infrastructure in place to know who in their neighborhoods in Havana and Matanzas, who was elderly, who was immunocompromised, what illnesses they had. They had already spent the past decade going door to door, hosting public forums, writing down people's information, knowing the needs of people. And so when the pandemic happened, of course, this is a difficult time, but they already had done the legwork as an organization, as a radical revolutionary community organization. They had already done that work so that they were able to operate at a level that impacted the public health of entire Black communities in Cuba specifically. And I keep on talking about Cuba because I see Cuba as an African nation and it had an African revolution, right? And so this public health work that community organizations like the Red Barrial are able to do is itself sustaining this revolution. And so the last time I was there in August, we had large donations of vitamins, multivitamins, vitamin C, all these different vitamins that they asked for. They have specific lists they provide anytime anyone from the US comes, and they want us to bring suitcases full of these things. And they had lists of everyone in their neighborhoods and their communities, and they began dividing, this person needs this medicine, this person needs this vitamin, this person needs, and it's not always just medicines. Sometimes it's things like tampons and condoms, right? Like there's baby food. I mean, there's a multitude of health and wellness related items that are denied due to the blockade. And because they have this infrastructure in place, of course, it can't compete with an entire blockade, but it sustains communities through this public health orientation. And part of that too is addressing racism, and helping the state find wherever there may be gaps or disparities in resources. So I wanted to, throw that example out there. And I think I can turn it back over now to Dr. CBS for some quick Q&A. Charisse?
Hey, y'all. This was such an amazing, thorough, excellent, wide-ranging discussion. So thank you, Sandy. Thank you, Dev. Thank you, Mama Patricia, for enlightening us. So we have some questions in the chat that I want to get to, but I want to ask a question that's sort of thinking with a comment that was in the chat about, so we know that like public health and disaster relief has also provided cover for entities like Southcom, right? The Southern Command, or AFRICOM, the Africa Command, to intervene in countries and continue the militarization and the oppression of the people in the global South. And so in that way, these global public health initiatives are actually tools of imperialism. And so how do we combat that? Like, how do we root public health concerns in the people and not in the state apparatus, including the United Nations, right? Which does not represent the people often. So how do we make those distinctions? What are some things that we can do?
That's a very loaded question. I think it's about education, grassroots education, because a lot of people don't know in Africa about AFRICOM. AFRICOM presents through a medical model. It does a lot of disaster preparedness. Actually, I worked alongside African people in Africa doing disaster preparedness. So they're very ingrained, not with the population per se, but they're very ingrained with the state apparatus. And so in order to counter that, it's more grassroots education that's needed to inform people, because people may see them as the good guys coming to protect us from, or helping us to set up a disaster preparedness model, which I think that it should be, the disaster preparedness model should come from a bottom-up, a community aspect. It's a rather top-down approach, because it's a model that's being introduced into Africa. So how do you convince African leaders that this is not what is needed? I mean, I don't know how you answer that question. Perhaps getting more activists involved in the discussion and linking those discussions to what's happening in the US, because I think more people in the US, understand what AFRICOM is about than people actually on the continent, because they don't get as much information about what AFRICOM is doing throughout the continent.
Yes, that is such a great question. I did see it in the chat and I'm like, yes, I'm glad someone brought up that public health can also be used in this way. And I would be remiss not to mention, in the case of Puerto Rico, the sterilization campaigns of the 20th century, as well as the birth control experiments done on the pill, with the pill on Puerto Rican women. So, all of that was supposedly like a public health solution to the issue of overpopulation, that all throughout, from the moment, 1898 onwards, the kind of discourse of overpopulation, right, was continuously brought up in Puerto Rico. And it's like, look at all these impoverished women having 10 kids and they can't feed them. So actually we're bringing them health. We're bringing them access to this thing that's actually going to help them. It's funny because with my students, sometimes we watch documentaries about it and there might be some women in the documentary who are like, actually, it was really hard having 10 kids one after another, right? So but that's exactly how they get you, right? Because it's like, oh, it seems like it's something, right, that is going to bring some health or access, reproductive rights. But, when it's couched in the whole issue of overpopulation, when there's not an analysis of how the imperialism, capitalism, histories of colonialism made it so that all of the resources were taken from Puerto Rico, so that basically an island of what at that time 1-2 million people couldn't even feed itself, right, or whatever it may be, is so that's a really big way that a public health policy damaged and hurt a lot of people. And then another, also in the Caribbean, prostitution policy. So as I had mentioned before, in the late 19th, early 20th, with like literal US troops occupying, right, one of the issues, it's like, oh, there's all these STDs, like our poor troops are getting syphilis. So, their public health thing was like all, again, couched in the discourse of progress and civilization in that time, was like, well, we're just gonna force women to be inspected like once a week. Like, so if you were suspected of being a sex worker, you were like criminalized or forced, you were subjected to these like really invasive, like examinations, like really violent. Like if they did find you with an STD, they were treating you, but they were treating you by like shooting mercury up your, your vagina, right? So it's like, yeah, those are two examples. How do we stop it? I guess I'm so inspired by Dr. CBS, always like, right, analysis, like really sharpening, studying, being in conversation, community, centering the community, and what Dr. Rodney says, being careful of any top-down initiative. So, yeah.
I think the whole thing about overpopulation is still being pushed by people like Gates Foundation, that we have to stop people in Africa from having so many children, and blaming women for the situation that they find themselves in. I mean, and experimenting with women on the continent, whether it's the IUD or other contraceptive drugs, under the guise of family planning, another public health, gesture.
And I think that, imperialism is a domestic violence as well, right? And so we think of, for Black women and Latin women in the US particularly, there were for decades massive campaigns to hit certain quotas for long-acting contraceptives to be implanted, right? Never mind the fact that a doctor has to take that out physically as well, which is an issue that they, wash their hands of course. But this is an act of violence, right, by this medical industry in the name of public health on Black women in the US, right? And so I think a good comrade of mine in Atlanta, Abu Shawareb, he's a doctor here in Atlanta. He speaks out a lot about that, as well as how through this notion of public health, the medical system works with defects and arms of the state to enact violence on the Black family unit and poor working class family units, oftentimes right there in the hospital, the very place where you're told you're supposed to go to receive health, right? And so I think those are some ways that this guise of public health can at times be used as violence. Or even if we want to take it international again and look at Venezuela, 2019, when the US aid finally said they were going to send a massive package of health and food aid through the border to Venezuela. Of course, the Venezuelan government said no, because there's a long history of the US aid being a vessel of imperialism and neocolonialism and working hand in hand with the CIA, of course, the US being an enemy of Venezuela. But they use that narrative to say, look at Venezuelans The Venezuelan government is denying its people this food and health aid. They're denying these people their access to this aid that they need desperately. Not mentioning that the reason they may need these things is because the US sanctions are quite literally snatching pills and food from people's mouths, right? And so I think that's another glaring example of, unless you have an anti-imperialist analysis, you can't often make sense of these things that happen on such large scales, whether it's domestically in the US or abroad. It's hard to make sense of the negative aspects of these things without it being rooted in an anti-imperialist and ultimately anti-colonial politic.
Excellent. So I'm gonna detail the answers so we can get to as many as possible. No shade. Okay. So these all sort of accrue around the question of patriarchy. The first question is, there are those within our movements that would seek to maintain patriarchal structures through the guise of religion or spirituality. Can you elaborate upon these structures negative, or how these structures negatively impact the health of marginalized people throughout the African diaspora? The related question is, how do we emphasize the importance of dismantling patriarchal structures for the benefit of collective well-being, especially for boys and men? And then the third related question is, what is the public health approach to dealing with chronic traumatic stress imposed directly or indirectly by white supremacist, capitalist, patriarchal violence?
I can go first if no one else wants to, because my answer is going to be brief. I'm actually going to touch on the one you mentioned, the second question, I believe, which had to deal with sort of patriarchy and how dismantling patriarchal structures can help everyone, including boys and men. And I just wanted to sort of direct people towards the work of Rennie Touré and Tommy Curry, who both specifically talk about Black boys and Black men and their public health issues as it relates to sort of formations of gender and patriarchy. And with that said, I think we have to look at patriarchal violence itself, one, as ultimately deriving from the capitalist state or imperialist state. Police and the military are the ultimate form of patriarchal violence. We know that all across the Caribbean, most of Latin America, wherever US and Western troops touched down, for example, you had a network of sex trafficking and sex work that began to pop up around the military bases. You had communicable diseases, which were spread through military occupation, degradation of almost all life and health indicators follows a US military base. And that includes domestically in the US. So if you're within a 5 to 10 mile radius of a US military base here in the US, for example, they say it's the equivalent of living next to a landfill for health purposes, right? And so I think that for me, my answer to that is that patriarchy derives itself from the state. That is the first and foremost. So I just had a short answer. I'll let the two of you, take that though.
Yeah, I'll quickly mention as well, somewhere in the chat, I mentioned a good friend of mine who's a human rights lawyer in Dominican Republic of Haitian descent recently started this organization called Fundación Código Humano, like the Human Code Foundation. But some of the work they're doing, and they're still kind of starting out, so you might not find too much more besides a webpage and an Instagram. But part of what her vision is, Altagracia, is really dealing with issues of sex tourism, teen pregnancy, and also a lot of the violence that gets directed to LGBTQ communities, like, so corrective rape, like that's still, that's even that's happening as well in Dominican Republic. So yes, all of that has to do with patriarchy, I believe, right? You think about things like sex tourism, sex trafficking. I also made a note here that I think it has a lot to do with mental health. So I want to bring that into the room as well, like the importance of, and then it relates to the question about PTSD, because I really do believe that sometimes, you know, when it comes to dismantling patriarchy, it's really just a mental kind of process of how, yeah. So anyway, and I think it has a lot to do with the mental health of the kind of violence that people who are socially constructed as men and boys face, but that it's not always just physical, but it's that kind of like that policing that they receive from a young age to be a certain type, like to act a certain way because they're men or boys. And then that how that leads to then the actual physical violence, such as domestic violence, sexual violence. So I think mental health is really important to dismantling patriarchy.
Yeah, I think the militarization of the society has a lot to do with the patriarchy and how men relate to women. Because if you're fighting in a war, there's certain norms, and those norms are transferred into your personal relationships. And that's why I call it violence against women, because that's where we see an increase in that violence across the Caribbean. It's one of the major concerns of women's organizations, that our male counterparts are oppressing the people who are closest to them. And how do we change that in terms of socialization? It's not just in mental health, it's how do we socialize our men and how do we socialize our daughters? And if we don't take those things into consideration, we will continually have this kind of patriarchal structures that we have inherited and that we continue with. Well, in preparing for this, I wanted to know if it's possible at all to talk about a people-centered healthcare and human rights within a capitalist society, because all the contraindications show that it's very, very difficult under capitalism to develop any kind of structure that addresses humans' needs and humanity of people.
Period.
And if I could just piggyback on that real quick too, Sharice is gonna kill me later for cutting her off, but I want to say one of the things that when we think of the Cuban Revolution and patriarchy, people often point to the representation of women in the Cuban state and in sort of positions of power, which is itself an achievement. But on a family level too, they have what's called the family code, which they're actually currently, right now, they had over 76,000 public forums, debates, and discussions to rewrite and add new amendments to their constitution within their family code. And inside this Cuban family code, it enshrines the rights of not only women, but children. It enshrines the rights of children as individuals with inalienable rights. And that includes all of the rights which are guaranteed under the Cuban Constitution. So that means they have a right to food, they have a right to housing, they have a right to healthcare, they have a right to mental health services, they have a right to education, dignity, et cetera, et cetera. And then on top of that, Cuba had an entire sex trade industry, a trafficking industry linked to the US, specifically in Cuba's case. And the way that and this in itself created a element and a climate of domestic violence, particularly in cities like Havana, Santiago, Guantanamo to an extent. And so what they did, they had massive campaigns across the island, which took individuals forced into the sex trade and put them into school for things like nursing, to be teachers, doctors. Free education meant that you also get to come and be empowered, right? And so the way that they handled that was actually by giving more resources and empowerment to those individuals. And so I think when we think of patriarchy in Cuba, we have to keep those examples in mind as well.
Thank you. Okay, so the next three questions that I'll bunch together sort of have to do with endogenous care within our communities. So the first is, how do traditional medicines as complementary or an alternative to allopathic medicine factor in the discussion? I think allopathic means white. I'm just kidding, I don't know. Western. Okay, the second question is, how do we address the closure of healthcare clinics and the opening of white-led for-profit urgent cares in our communities? And I just want to add, that's probably very parallel to the no banks, but a lot of check cashing places, right? So these things that gouge our communities. And then the third question is, as socialists, communists, Pan-Africanists reflecting on the Black Panther Party and Young Lord's guerrilla health programs, can y'all discuss any strategic benefits to organizing around or imagining contemporary mutual aid networks, medical and other? And if so, what are the limitations or pitfalls or any advice y'all can give to younger students and organizers placing energy into mutual aid efforts when organizing in coalition to larger movements toward radicalizing public health infrastructure? So pick all or one or any of those to address.
Well, I guess I'll go. I just wanted to say yes about the irreconcilable contradiction that exactly one of the main solution is exactly dismantling capitalism. So we're definitely going to continue working on that. Questions of sort of alternative medicine and then maybe futures of how mutual aid could kind of get us out of some of this mess. And then, but also just that kind of ongoing process of privatization. Okay, well, maybe I'll just go back again to Ana Livia. I mean, one of the things she always centered with her organizing after she did all of her travels around, Ghana, New York, Cuba, she traveled to Cuba as well, Egypt, during this kind of moment of decolonization, is that when she returned to Puerto Rico in the late 60s, she started this grassroots organizing campaign. And a really big part of the proyecto, as it was called, it was the pilot project for work with the people. One of the guiding principles was that kind of human-centered aspect, that capitalism does everything in its power to completely negate the kind of the humanity and the love and the care. That's like what they talked about, amor, cariño, right? Like that's so much of what they were doing. And my understanding is that was also the discourse in Cuba after its revolution, right? The kind of creation of the new man and woman, the kind of, that's such an important part of the process, that sort of individual decolonization process where we reconnect with the kind of human sides of the interpersonal, the love, and that we try to, one of the great, in order to counteract the effects of this capitalism is to kind of then fight against all of that alienation and violence. So that's something that they always, at least having our principles, I guess, Black Panthers, Young Lords, they had their very, 10 or 13 point programs, and always making sure that whenever we create those statements of our goals and our values, that then exactly that we're stating it really clearly and trying, again, Dr. CBS always talks about ethics. So exactly like really paying attention to the kind of everyday ethics of our like literal everyday, the way we act. Yeah, so.
I will second what Sandy says. I believe that I am troubled that most of, or even our progressive organizations depend on funding from sources that are not ethical in terms of doing their work. And sometimes you have to follow whatever policy those funders lay out for you. So we have to find another way of making sure that our grassroots movements are, what's the word I'm looking for? Can support themselves and not depend on funding in order to do the kind of work that is critical at this time. And perhaps it takes organizations coming together. There are lots of organizations who are working on the same issues, but not talking to each other. So even our organizations, activist organizations, are very fragmented. We all working, some of us are working in environment, some of us are working on women's reproductive rights, some of us are working on prisons, police brutality, but those connections are not there. And perhaps that may be the solution for us to begin to talk to each other and to integrate our work to see that we're really dealing with a human being or human beings. We're not dealing with parts of people. And again, like Dev, this is where Cuba shines a light that people are seen as human beings first, and then other things can fall into place because you're working with people from the grassroots level who are the ones who are doing the education. It's like each one teach one. It's not just professionals coming and talking to us about something. It's the grassroots people who are setting or demonstrating what kinds of policies they want to see happen within that society. And I think that's critical for all of us to reassess the work we're doing and to see how we can further collaborate, because that builds strength. If we're individuals, they can destroy organizations like they did with the Black Panthers or other organizations, because you're fighting that issue on your own.
Absolutely. And I want to uplift what Brother Jamu Baraka said in the chat. Mutual aid must be seen as a tool, not an end itself. I second that. Until we have ended capitalism, we have a revolutionary people state. Mutual aid is to sustain and survive pending revolution. But to the first question specifically, and I might be off base a little bit, but I believe they were talking about sort of the shift to emergency medical centers and urgent care centers. And so there's actually a historian and activist, Nick Ramos, N-I-C Ramos, R-A-M-O-S, and he speaks specifically about how mid to late 1980s, maybe I'll just say the 1980s, following as a direct response to the revolutionary and radical movements of the 60s and 70s, and the way that they reshaped how people think about health, but also the rebellions and the riots and the police precincts that burned, we actually saw a sort of reintegration of privatization of healthcare, where in the public health community and field itself, there was a shift from the goal, sort of the larger, one of the goals being a polyclinic in every community, or a clinic in every community, or health workers being embedded in every community, to instead have emergency departments and having access to an emergency department and being able to call an ambulance. And he marks this specifically as an example of, and I don't want to mess up his words, but basically that this inextricably links policing with healthcare in the US. So now what you have is health itself policed, whereas before there were community care clinics, patient-oriented care clinics, and polyclinics. You now have an emergency department, which is ran privately and is a cash business essentially, wherein if 911 is called, police or an EMT, which is a police light, basically accompany health professionals. And so he maps that entire history of how we got to where we are today, where I can drive past 20 private emergency care units and emergency centers, but there's no actual community care clinics. So I would recommend looking at the work of Nick Ramos. Yeah, I'll just leave it at that.
I was going to say in the Caribbean, we have polyclinics, and that came out of the Alma Ata Declaration. I think the polyclinics themselves, from when I last studied them, were still in the traditional mode of a top-down approach, not really getting into the community and doing the work they can. I hope it has changed, but I don't think so. I think the community clinics are an excellent venue for having the kind of discussion we're having, talking to people, getting to know what people's needs are. So that's one thing that is sustained in the Caribbean, the community health centers or polyclinics. What needs to happen is using them in a more concerted way of teaching health and well-being.
And I'm sorry, Cherise, I'll say something, I promise, super quick. It's just that exactly that there's such a range of healthcare workers. So it's not just people with MDs. You know, you can have an MD, you have an MPH, but there's so, you know, community health educators, there's midwives, there's nurses, nursing assistants, like, you know, after the revolution, some of those labels may be different, but just realizing that there's so many different types of health work. I think that also, to me, that's what I think we need to keep in mind as we move forward as well. So. Okay, so I'm gonna bunch some more questions, but also shorten them. Some of these are like paragraphs and they're long. Okay, so the first question is basically, can you guys define what quality patient care and quality public health should look like? Related to this is a question about housing that basically, what work do public health activists need to do on the housing front? You know, especially because, you know, the way that public housing has been attacked as a public health hazard, when we know that it's the privatization of housing and the lack of housing and insecure housing, that's a public health hazard. And so basically the intersections of work around housing and work around public health. And then the third question is, oh God, okay, this is a long one. All right. So, given that conditions of Black life, past and present, are largely experienced as unfreedom, and nearly all human endeavors or areas of life shape the context in which reproductive and bodily decisions are made, and Black liberation is political and psychological work, which frameworks do you see we need to learn from and leave behind? And which frameworks or political strategies are capable of working simultaneously so that all Black people may embody and experience freedom? So one is about, so just to recap, one is about sort of what are the frameworks that are most conducive to Black liberation and which might we leave behind. One is about the intersections of housing, organizing, and public health work. And then one is about what does quality patient care and quality public health look like?
Well, when we talk about public health, we always talk about the social determinants of health, which is not just looking at ill health, but looking at those social conditions that produce ill health. So you're looking at the environment the person is living in, the housing conditions, the access to food, access to getting to medical care, education, literacy, all the jobs, unemployment, all those things that are important if somebody is to have or live a quality life. So we can't separate health from those other things. That's what makes you healthy. If you don't have those things in place, you become unhealthy. And so the model that we've inherited is one that treats ill health and not the sustain or the quality of health. So we have to reorient ourselves in thinking that health is the way we live. It's our culture, it's part of the food we eat, it's family, it's friends, all those things make somebody healthy. It's not a healthcare system that makes you healthy. It's the quality of the life you live. In terms of patient care, is really treating the patient as somebody who is knowledgeable. The person knows their body. And so how do you have that dialogue if doctors are not trained in that model to talk to patients as equals? So it's the model that needs changing, not people that need changing. And again, we go back to Cuba, where the doctor talks to the family, not just the person, the family, about what is going on in the household. There's a discussion that's taking place. There's an understanding that what is my role when I come to you as a patient. And in this society, I tell people, if you're going to see a doctor, you make a note of everything that you are doing. Some doctors will encourage you to talk. Some don't want you to talk, or they're not listening. Their main thing, and it's because of the way the structure is set up, that they have to see a certain number of patients within a particular time frame. So you need to be prepared when you go to doctors. Like, you know, I used to tell people when I ran a public health clinic in Barbados, treating transportation workers, that people tend to spend more time, invest more time if they're buying a car than they do with their own health. They want to know how this knob works, what kind of music they could get, what this, that, all the things that come along with it. But when it comes to their own health, they hand it over to somebody else. So we have to take responsibility as patients for our own health. And if you find your doctor is not communicating with you, find another doctor. We do that when we're buying a house, or if we're choosing a partner, or if we're doing other things. We can make the choice and say, this doctor does not fulfill my needs as a patient. I have to research and find a doctor that will listen to me. In terms of public health, again, it's public health professions becoming more connected to the communities in which they work. How do we not? And the thing, I want to say this about the Grenada Revolution, that I admired that aspect of it. Like, a minister of health did not write a 5-year development plan sitting in the office. He went out to the community and found out what were the needs of those communities, and then developed the plan. And that's a different orientation, again, that you are seeing working people, community people, as people and not as subjects. That you are there to provide them with the services they need. It's your right. That's why health in Cuba is seen as a human right. And it's not a privilege that people can put on the marketplace. You can buy it as a commodity.
You answered the question so well. The quality of the life you live. Yeah, that was just exactly. I was thinking a little bit about exactly that we have to then expand that health workers, there is an interdisciplinary nature to it. You're not just like a science nerd, you know, you need to be someone who also gets training in social sciences, so sociology, anthropology, and then you should have that, like, what humanism, like, yeah, you should probably be reading poetry or literature and kind of the arts, and really, because when you really think about it, you're dealing with exactly human beings. You're dealing with people who are completely different, who can have a range of, I mean, you really, it's just to kind of take it out of, again, the medical education model. You know, I was pre-med at one point. Some people might relate that in this country, when you're pre-med, the whole way it works is to weed you out. Like and you know, me coming from my background, it was like, oh, I didn't have the right scientific and math training. So I was certainly weeded out. And it was like, wait, my heart was in it. I really, you know, now I just write write about, doctor. So that's like but I always think about that in the alternate reality, but because part of it is I don't think they were seeing, right, the sort of holistic, like maybe I wasn't perfect at like calculus or whatever, but we all know how those things are so classed, right, those skill sets. So that's something to keep in mind with the quality patient care, public health, how to kind of be more holistic in the way we train the health workers and in terms of how we see what skill sets are needed. Housing, yes, absolutely important. So, and then, yeah, I'm just glad that Cuba keeps coming up. Something related to alternative medicine that came up before, that also not being too afraid either, right, of going back into our communities. Like, I think we need to do that work of like talking to our grandmas about the remedies. And because as we know, a scientist in a lab somewhere will figure out, oh, boiling this herb, and our grandmas have been doing it for hundreds of years, right? But until it's like kind of taken into a lab and made into a pill. So I actually, I know that you have to kind of work with the scientists, but I actually think we have so much knowledge as well. So I don't know if that's the role of kind of like anthropologists or sort of people like that to kind of go into our communities, right, decolonial anthropologists, right, to kind of go into our communities and just gather some of those healing methods and really like examine them, see how we can improve, etc.
And I think that, and there was a question, maybe it was the last round of questions, my brain works funny, I'm sorry, but you hit the nail on the head when you said go into the communities. And I think there was a question about when we're building our own organizing, where we should, what we should do. And the reason I said the Cuban example as I did was because the Cubans use Paulo Freire popular education specifically. And the basis of popular education is a needs assessment and an assessment in general of the community and the population through which you're trying to serve, right? So the one of the most famous examples was he was trying to teach farm and agricultural workers in Brazil to read, and he learned through their interest how to teach them literacy, right? And so in the Cuban context, I said earlier about that they already knew the needs and information about their community. And so in the US, if you're trying to replicate any of these models we've discussed, or you're trying to build something sustainable, especially, but not just sustainable, but useful as well, you have to first know what the community actually needs, right? I mean, we've had initiatives pop up in neighborhoods where you live in the neighborhood and didn't even know what's going on because it's not even in your purview and it's not even something, right? And so if no one comes to you and knocks on your door and has a relationship with you as an organizer or a healthcare worker and ask you what it is that you need, you might get elderly people saying they need help getting to and from doctor's appointments. You might have a large group of single mothers telling you that there's mold in their building, and that is a health issue and that needs to be addressed, right? So going into the community and as organizers, us not being afraid of learning how to do a needs assessment and a diagnosis and operating from that basis, right? Just like Patricia Rodney said during the Grenada Revolution, the health minister who wrote their, health policy did so in the field on the ground, right? And so organizers in the US, the Black Panthers, the Young Lords have been brought up. This used to be a skill and a tactic that we were very attuned to, that it was understood as a basic, especially as it relates to health related things. And I think we have to bring that tradition back of not being afraid to do a needs assessment. And maybe that needs assessment lasts 1 or 2 years before your initiative even begins to start operating, right? And that's okay. Be methodical, be scientific with what you're doing. Don't waste your time and don't waste people's time. So I just wanted to throw that out there.
I think we also, when we go into the community, we have to go in being not judgmental. I remember taking students around the West End to just get a feel of the community. And when we came back, I asked them, what did you see in the community? And all they could see was problems. They never saw the assets within that community. So it's our own educational biases. And most of us either come from or attain middle class status, and we forget that what are some of the important things to look for in a community. And as Dev said, doing a community needs assessment, but not doing it from your perspective, getting people to tell you what is going on in the community. I remember them saying, oh, these guys were just hanging around on the street corner. And I said, how do you know that they hadn't been working last night? And this is the way of relaxing and dealing with their stress. But is this perception that we go into a community and we know what's good for the community, or we judge the community based on certain standards that we have acquired? Something that drives me crazy is when academics talk about those people, and they're talking about people like themselves. They are repeating what white academics say about us. They're regurgitating the same messages. So it's not everybody who could do community work. You have to be trained to do community work. You can't just go into a community, because you may come out with the wrong answers and develop the wrong policies.
And I know we're close to wrap up. And Patricia, thank you so much for that. I love it. And I just wanted to say real quick too, there's also the street medic model. And this street medic model is a sort of radical-ish model. There's radical tendencies within the model that tries to bring these medical professionals from emergency rooms and doctors' offices to work with populations and houseless people and sex workers. A great friend of mine runs the Atlanta Consortium for street medicine. And so we have to support the initiatives that already exist too, and embed ourselves in them to make them more radical and more, useful for everybody. So everyone look into the street medic model and street medicine model as well.
So hit up your weed, man. I'm just kidding. Okay, so thank you all so much. Strike that from the record. No, so we are gonna move toward closure at this point. But just to boil down some things that were said, organize, join an organization, do your mutual aid in the context of an organization. It's a means, not an end. Do not be afraid of the people. Do not judge the people. Hide nothing from the people, as Amilcar Cabral says. Public health is a people-centered human right, and police, the pigs, the military, undermine that in every way, right? That they are in and of themselves a public health problem. There was so much that was said that, we need to challenge patriarchal structures. We need to center what community health workers are doing, what women are doing already in our communities, and take that as knowledge in and of itself, even as we're building other types of resources like public health clinics. So thank you all so much for these wonderful comments. I wish we had more time. Y'all know I'm a tyrant when it comes to the time, just so we can lift up as many voices as possible. There were some questions we didn't get to. I'm so sorry. But this is an ongoing conversation, right? Take these points, take these questions back to your organizations, back to your communities, back to your reading groups, so that we can turn this discussion into praxis. So I want to thank our operations team, our wonderful, wonderful, wonderful ASL interpreters, our presenters, and all of you for being here this evening. Of course, as always, please do consider joining and donating to the Black Alliance for Peace and the Solidarity Network. Please do consider joining or donating to the Walter Rodney Foundation and attending the wonderful events that the foundation organizes. As well, do check out and share BAP's video on all the work that BAP members engaged in last week to counter the Summit of the Americas in Los Angeles. Special shout out to BAP LA for doing so much work. So thank you all. And as always, here at Black Alliance for Peace, we say no compromise, no retreat.